That's a really tough act to follow. I just want to start out by saying I really echo the first speaker. This was such a difficult enterprise to condense 4 days of learning and years of work and effort from all of you into a now 9-minute and 42-second presentation. I will say that as both someone who was raised in the church and a child of immigrants, I'm very prone to guilt and shame. So if I left you out, I'm so sorry in advance. Okay, so let's jump in. So if we have to step back and look at the theme of epidemiology and public health, there were, in my mind, 3 things that really stood out to me. And what I will say is this is, as of course, built into the heartbeat of INHSU, which is looking at hepatitis C and HIV in people with substance use. But I wanted to highlight a couple of the other topical areas that really stood out to me this year in this theme of epidemiology and public health. And the first is, overdose, which is the very real reality that we are living with. And myself, part of the North American contingent, this is very important to us. So we'll start out with a few examples of work that's being done all over the world. So first, work out of the University of Montreal utilized public health data looking at nearly 90,000 records of overdose deaths over almost 60-year time period. And what they found was really 2 waves of overdose-related deaths. The first initial link to opioid prescribing that was really booming in the 90s to early 2000s, and then the second wave that's really driven by fentanyl and other synthetic toxins. Another unique feature of these findings was that there was a difference between the west coast of Canada, the British Columbia provinces, and the eastern provinces in the rate of death, even when factoring in population. And this really speaks to the importance of local, geographic, and social context when looking at overdose and overdose mortality. Another example was out of Kenya, and this was presented by Ryback et al. And what they did here was they recruited over 3,000 people who use drugs from across Kenya at the locations that are indicated there, and followed them and at baseline conducted surveys where 14% reported experiencing a non-fatal overdose within the last 4 months. And this overdose was associated with polysubstance use as well as injection practices, including high-frequency use and use alone, which I think, again, really highlighting the importance of these contextual, individual social factors. Another analysis out of Greece by Dr. Sipsa et al. Was a cohort investigation of over 600 individuals, and they reported a 50% rate of lifetime overdose, non-fatal overdose, with very high rates of observed fatal and non-fatal overdose. And this is very important because when we think about who are the experts when it comes to understanding overdose, it's really people with lived experience, because that's their friends, neighbors, loved ones that's witnessing what's happening behind all this numbers. Unfortunately, another key piece of information that came out from a formal knowledge assessment done in this cohort was that there was, although naloxone only became available widely in Greece in 2021, there was really limited knowledge around how to utilize naloxone or how it even worked. And in this era of misinformation, I think this highlights how important it is for all of us in the public health community to be understanding and educating one another on naloxone and its life-saving capacity. A couple studies out of the US just wanted to highlight. So moving from one side, Jagaday and colleagues out of the University of California, San Diego, did a modeling study looking at the contribution of fentanyl to rates of fatal and non-fatal overdose. And unfortunately, the model really matches our lived reality in the United States, that fentanyl was really associated in this modeling work with at least a third of fentanyl with overdose death. And without fentanyl, thousands, hundreds of thousands of individuals could have not experienced non-fatal or fatal overdose. Another study out of Kentucky with the landmark, Healing Community Study, looked at naloxone distribution, and of over 13,000 units of naloxone that were distributed, the most successful, or the largest number of naloxone, was really in those community-based settings. Harm reduction and syringe service programs, again, relating back to that expertise of community. And then lastly, an analysis from Skinner and colleagues out of Brown used a really unique analysis where they used calibrated machine learning techniques to create a map of hotspots of overdose within the city of Providence. And how they're utilizing that is using this to prioritize how they can deploy resources towards these hotspots of overdose. And then finally, a unique analysis by Goodman-Meza et al. Out of the Kirby Institute found that while overdose rates in Mexico have been significantly lower than the United States, that ultimately this may be a challenge of underreporting. And I have to believe that this is a challenge that we may be facing all over the globe. And so what they did in this analysis was utilizing decedent data and analyzing potential proxy ICD-9 codes, so coding codes that aren't overdose, but could be likely related to overdose death. They redid an analysis that ultimately demonstrated with an overdose curve very much mirroring that of the United States, although lower rates. So just stepping back, looking at this theme of overdose, there are problems with reporting overdose, and even in countries without a fentanyl poison drug supply, unfortunately non-fatal and fatal overdose is common. So the opportunities in this, really from a public health standpoint, we need to ask about overdose. Every single time we're encountering a person who uses drugs, we need to ensure people who use drugs and direct service providers have access to naloxone, and look for those regional variations that can help us triage our overdose response. And also, just as always, a plug for the Safer Supply program, because at the end of the day, we do not control the fentanyl that's in our toxic drug supply. Another major theme from the public health standpoint was looking at the incarcerated population, and we had two amazing talks that were meta-analyses conducted out of NDARC. One led by Dr. Degenhardt really looked at the rates of injection drug use, HIV, Hep C, hepatitis B, and along an incarcerated population. And what you can see here are the staggeringly high rates in incarcerated populations of these various diseases. So as was described, we have a concentrated population with a disproportionate burden of disease. And unfortunately, as Dr. Santo described, there are very limited rates of treatment that are available in the carceral setting, and you can see some of those listed there. And the other part of that analysis was that there were these services were scattered, so very few jails or prisons that had data that demonstrated one or more of these services. And then I think the last major area is syndemic bacterial infections. I wanted to highlight 3 different analyses that were looking at the high rates of other bacterial infections, including skin and soft tissue infections that people who use drugs experience. And these are often complications that land people in the hospital and land them with very serious illnesses with high rates of morbidity and mortality. And then one analysis out of the Burnett Institute looking at high rates of syphilis in women who use drugs, and that this was unfortunately found despite really low rates of testing. And we know that globally, syphilis is on the rise despite having excellent therapeutics. And then I did want to put in a plug from a public health standpoint that Dr. Spearman reviewed the hepatitis B simplified WHO guidelines. And I thought this was really amazing that there's strong implications for public health programming here and decentralized treatment. So the summary is do more, and I have to say, unfortunately, with less, because we all know that the current funding climate we're in And I think Dr. Matai put this really brilliantly for all of us, which is that there are real harms with the situation that we're facing now, with the lack of investment in public health funding. And so what I'll leave us with is just the importance of integrating care across the syndemic health of people who use drugs. I think we can utilize epidemiology, as was said in an earlier plenary today. How do we know what to do for what sets of people? Let's use the science to help us triage these services. And just remember, as we're talking to people who fund us, when people who use drugs, when their health is maximized, everybody's health is better. If we can build public health structures to maximize these services, we all benefit. Thank you so much.